Can I begin, Kim?
Yes, I can hear and see you.
Okay, so I'm going to start. Do we have some participants? Yes, we do. Welcome, everyone. This is session D, a new clinical manual for training memory compensation in moderate to severe memory dysfunction. Just before we start, I will let you know that there will be time for questions at the end of the talk. And in case you haven't experienced it yet, there are two ways to ask questions. You can either put a text-based question into the Q&A tab, which you can see on the right side of your screen. You can go ahead and type questions into that tab throughout the session. And if someone has asked a question that you think reflects the same information you're interested in hearing more about, you can upvote another's question and it will raise that question to the top so that as we look at the questions to share them with the presenter, we know that something is commonly being asked. The other option is to raise your hand at the end of the presentation, which will allow you to enter the broadcast and ask the question verbally. You will be called on by name, and the technician will then give you permission to come into the broadcast. You will be prompted to turn on your camera and microphone to go on and ask your question. And I'm just going to move right in to this exciting content. It is my pleasure to introduce our speaker for this session, Brandon Vasquez. Brandon received his PhD from the University of Toronto, and he's a registered neuropsychologist at Baycrest Health Sciences. He has clinical expertise in memory intervention for individuals with moderate to severe memory impairment due to acquired brain injury. He holds assistant professor status at the University of Toronto in the Department of Occupational Science and Occupational Therapy, and he researches learning in amnesia and the use of technology in cognitive rehabilitation. Brendan, I'm going to invite you to join me on stage. You will simply turn on your camera and your microphone, and you'll be good to go. You'll share your slides, and we'll be ready. Hey, there he is.
Hi, Sylvia. Thank you. Okay. Just sharing now.
Perfect.
Okay, is that all good? Okay, so let's jump right in. So this is the clinical manual that I want to talk about today. It's a new book that we developed in our program, but really it developed out of our program, the Memory Link program. And so, today I want to talk about the background of, memory dysfunction and acquired brain injury, how we approach that in the Memory Link program, and how we've captured that within this new manual that we have. And I'll spend a little bit of time at the end just talking about some virtual online adaptations, which are highly relevant today. So to start off, acquired brain injury can affect, many different aspects of functioning. But we also know that memory functioning in particular is very vulnerable to injury. It can occur from various forms of brain injury, including those affecting the medial temporal lobe, of course, very important for memory formation, but also other aspects of the brain, such as the diencephalon and basal forebrain. But what the takeaway from this is that many forms of injury can affect memory functioning, and so it's a highly prevalent condition following brain injury. Of relevance to what we do in looking at treating individuals with moderate to severe memory difficulties is that there are specific functions that really impair someone's ability to live independently. So these are some examples of some common memory difficulties someone may be facing. For example, remembering appointments or to do different things, to do different tasks or chores, taking medication. Frequently having difficulty remembering conversations is expressed, and so on. But the takeaway here is, some of these might be more important for independent functioning than others. So we may say that being able to take your medications on time is highly important, and so is, carrying out those daily activities that can get you by. According to the literature, there are, some guidelines that we can use to approach treating these individuals who have severe memory difficulties. So what we know is that, the use of external compensations is the primary recommendation. And what this really just means is training the use of memory aids, but directly training them in the context of how they'll be used in daily life. There is also an option that's recommended, which is the use of errorless learning techniques, which I will talk about in a little bit. So in our program Memory Link, which is offered through Baycrest and has been offered there for many, many years, going back into the 90s before we even had technology, our current stance is that we want to use the evidence-based knowledge that we have from research in how to best address memory difficulties, but also link that with emerging technology and research. So in our program, we do train skills that are required for memory aid use. And following that, we facilitate daily life integration of these types of compensatory strategies. Our targets at the end are improved functional memory, increased independence, and enhanced quality of life. So the critical problem that we recognized and from the beginning and in the development of the program is that using these types of compensation strategies, and especially now with a wide variety of available mobile applications that are commercially available, they can be very powerful tools to help with memory. But critically, when someone has moderate to severe memory difficulty and may not have the experience of using these types of apps or the habit of using them, the memory dysfunction itself may be an obstacle to learning how to operate the app and effectively use it as a compensatory memory aid. So we take an approach based off years of research in memory, and this is a diagram of how we conceptualize memory, in that it's not a single unitary cognitive function, but has many different subclassifications. So often when someone has a very severe memory difficulty, we know that it's mostly affecting the memory for episodic events. So that's day-to-day memory, what has been happening in someone's life. It's it's a conscious type of memory. But sometimes, or often, we have other forms of memory that are spared. For example, some implicit skills are often unaffected by various forms of brain damage and can still benefit from learning in that context. So when we think about developing our program, we started from that point of view, with implicit learning being a key essential workaround to other kinds of memory difficulties. So we know that memory impaired individuals can show robust learning of these implicit skills, but it does develop very gradually over many trials. And the errorless learning piece, which I had hinted at earlier, in individuals with this type of memory difficulty, we know that since their conscious memory is affected, they may not be able to benefit from errors because they won't remember those errors along the way. So this can sort of confuse the learning of new skills. Therefore, errorless learning attempts to support learning while preventing errors before they occur. And lastly, we integrate something called vanishing cues, which is really just scaffolding learning along the way to provide as much support as is needed for someone to get to the end goal, and then slowly fade away that support as learning progresses. So our program provides a structured protocol, allows us to track progression. We use different kinds of cues, prevent errors before they occur, and fade that support as learning progresses. This mostly occurs within the first, what we call, phase of skill acquisition. So that's learning how to perform a given task, or the skills of operating, for example, a given mobile application. But then we also spend a lot of time working on something called skill generalization, which is just facilitating the use of those compensatory skills that we've taught them in daily life. This is just an example of how we further break down the steps of using a specific app so that it can be more easily learned. This is an example of calendar event entries broken down. So in stage 1, we might just focus on entering events for a single day. In stage 2, we'll move on to future dates. Stage 3, we'll spend a lot of time working on training how to respond to alert notifications once they arrive. And in stage 4, we can focus on other tasks of related to using that specific app. For example, what if you wanted to edit an entry or delete an entry, and so on. This represents the skill generalization, where we facilitate the use in daily life. This may require some collaboration with family members, community OTs, behavior therapists, and so on, and provides an opportunity for us to troubleshoot what might be, considered barriers of using these kinds of strategies in daily life. And although I did focus in my example on a calendar kind of app, which is very useful for reminding someone to do things at appropriate times, for example, making it to appointments, doing tasks, and taking medication, there are a variety of other apps that might be useful to individuals with memory dysfunction. So, for example, learning how to take notes in their phone, journaling, phone calls, texting, and a voice recorder, for example. These are all possible within our given training system. So I'll just tell you a little bit about the outcome research we have completed on our program. There has been several published studies on the MemoryLink program over time, but I'll just focus on some key points here. In this particular study, what my colleagues did was use phone call tasks to test people's ability to use memory aids. So, for example, if they were able to input a reminder to call the experimenter at a certain time, we can track those kinds of calls and call their use of the memory aid successful. Now, along the bottom here, you'll see some letters A, B, A, B. So the A's represent, I guess, the instances where our clients were not using our memory strategies that we've taught them. The A1 is before they even joined the program, and the y-axis represents the percentage of successfully completed phone calls. So it's not like they completed none, but at the most, their individuals were at 40%. Following the completion of the program at B1, you can see that there was a dramatic increase in the proportion of successfully completed phone calls. When asked to, in the A2 phase, to not use those strategies temporarily, you can see there was another drop. And in B2, when allowed to use those strategies again, there was a marked increase. So this AB design allows us to establish that causal link between using these kinds of strategies and success in these sort of everyday memory demands. We also found that about a year and a half later, after the program was completed in this B3 stage, individuals were still successfully using these memory strategies to help them, with these types of tasks. In terms of self-reported memory functioning, we can see that from pre to post training and 3 months later, as this graph indicates, memory mistakes for prospective memory, which is memory for intended future actions, decreased significantly over those time periods following completion of our program. And this also translated to some decreases in other memory mistakes outside of prospective memory. So that shows some some kinds of generalization to memory in general. And when we look at confidence in memory, we see that individuals' confidence increased as a result of our program, and even their family members, which is described by the other column here, they also noticed or felt that there was an increased confidence in their family members who were in the program. So it's sort of an internal self-reported, but also externally observed increasing confidence from our program. More recently, I've become interested in looking at the elements of training. So how someone learns to use different apps when they have these types of memory difficulties. And I know this slide is a little busy, but I'm going to walk you through it. We have 4 graphs here. Each of them represent the correlation between performance on a cognitive measure and how long it takes to learn the basic skills of using a calendar application. And overall, you'll notice that they all have a similar pattern in that it's a negative correlation between the given cognitive test and how long it takes, which is represented as trials to criterion. So what we can infer from this negative correlation is that when someone has a very a low performing score on a given cognitive test, they will take longer to learn how to use this given app. When they score higher on the cognitive test, they take much less time to learn the app. So what we can take away from this is that, especially with these first 3 cognitive tests, which are actually measures of memory functioning, is that although we're training an implicit system of learning by lots and lots of practice, we know that the more conscious form of memory, if that is more intact, it can support the learning of these types of skills. However, this last graph in the bottom right corner, this is not a memory test and represents more of a visual skill and spatial type of test. And this might tap into sort of that implicit or visual learning type of aspect that's involved in our program. Also in that study, I looked at how someone performs at the very beginning, the very first session that they're with, that they start with us. And what I found is a similar negative relationship. So what that means is if someone requires a lot of support to complete a given number of steps, then they take longer on the first session, then they take longer overall to learn all these steps. Whereas if they start off higher, requiring much less support, they require fewer overall steps. And we're interpreting this to mean that if someone comes to us with sort of more experience or fluency in using their given device or an app, they may not take nearly as long to learn all the steps that we need them to learn to use it effectively as a memory aid. So back to the MemoryLink handbook. So we've taken all those elements from our program, what we learned over the last maybe 30 years, and finally condensed it into a book that's available for purchase, recognizing that there's a need for this type of service and we can't be everywhere at once. So this is available on the Baycrest store for purchase. It's really designed for clinicians to help teach and train individuals to use compensatory memory aids. However, we recognize that there may be some situations where family members might want to participate in this, or may be more beneficial in some circumstances for them to take on that kind of role. So we do have a section in the manual that's a note for clinicians, a note for families. In the families section, we sort of stress that it's sort of better if those families are under the guidance of a clinician when using this book. The book is broken up into different parts and different chapters, of course. Part 1 is the nature of memory and memory dysfunction. Part 2 is training, which is the bulk of the book, and really focuses in on our method of training and how to train those types of skills. We have Part 3, supportive groups, and Part 4, some memory link success stories. I did want to highlight this one chapter, Beyond the Basics, which is in the training section, and this is really about our method of training is although we focus in our program on training different forms of smartphone applications. The reason being is that those applications are easily generalizable to a variety of contexts. So, for example, training a calendar application can be useful in a variety of situations in real life, whether that's remembering to buy something at the store, make it to an appointment, or take out the garbage. These are all, you train one system that can be applied to those different contexts. But we also recognize that you can use our techniques for any step-based type of learning. So this chapter focuses on that and uses an example of an espresso machine to walk through that. So, for example, if you really wanted to train someone to use an espresso machine and they didn't know how to do that, you could use our method to do that. We do support new trainers. We have some resources available that can be sent following the purchase of the manual, and that includes some training videos that demonstrate how we approach everything, but also allow the opportunity to practice scoring along using our method. And we also have some training forms that you can use as templates and adapt to your own needs. Okay, so I also, in the last section, I just wanted to take some time to, acknowledge that, things have changed in the last couple of years. And although our program was initially designed for, to train people one-on-one in person, we've had to make some adaptations to this sort of new world. So we currently offer most of our services virtually. And to do that, we had to think creatively. So what we really needed was a platform to communicate remotely with clients, ability to see what they see and provide guided support. We chose the Zoom platform, but others are likely possible. This is an example of what it might look like. We have a client and myself on one Zoom call, and the client also has their phone connected to the same call, and it has their screen shared, so you can see what they see. Some challenges that have cropped up. Errorless learning is compromised because we can't fully anticipate or see what the person is doing until they've actually done it on the screen. So we do have to be more careful about that. We can't use some of the cues, types of cues that we used to give that were visually based. As mentioned, behavioral signals from clients are missing, and it's sometimes difficult to provide tech support if it's before they've actually connected the screen share and we can't see what they're doing. This may require some additional time for setup and so on. But I will say there are a variety of positives. We see that it's convenient for clients. They don't have to travel like they used to. It's definitely allowed us to serve a greater wider variety of clients from various locations that could not have actually made it in person prior to the pandemic. It's a safe situation or modality for vulnerable people, and it's actually very well suited for teaching on our side of things. So this is a graph showing virtual training of an individual on the calendar application. And what this graph is showing is how much support is required for them to complete all the steps on a given trial. So as you can see, over time, they require less and less support and are completing it more independently. So higher means full independent completion. And for example, this person took about 17 sessions to reach that level. Some clients take a bit longer, like this one, who took about 49 sessions to get up to that 100% mark. But overall, we're seeing that virtually our training methods do show beneficial learning gains over time. It just depends on the individual. So what we know so far from from our virtual applications of our program is that it can be provided virtually, and it's still possible. We can see those learning gains in learning application skills. Clients seem to be liking, participating in the virtual environment and engaging well online. We do believe that it's a little bit less efficient, and I mentioned a few barriers or challenges involved in the virtual delivery. So clients may take a little bit longer when trained virtually. All right, so that's all I had for you today, and I'm happy to take any questions.
Thank you, Brendan. That was excellent. We do have some questions coming in. I will encourage people to type your questions into the chat. Sorry, not the chat, the Q&A box, so that we can have a bit of time with Brendan to dig in a little deeper. If you want to ask him specifically, you can go to the participant tab and we will invite you to open your mic and speak. I'll start with a couple of questions that have come in. Brendan, there have been several people who've asked. You did share it briefly. I'm going to ask you to share again information about where people can access the manual, get some of the details that you spoke to. I know you referenced the Baycrest website. Can you maybe just mention that again, please? Several people have asked.
Yes. I'm not sure how best to send the link, but I can maybe go back here. Oh.
There, yes, you had one which had the link on it.
Oh, was it here?
There it is.
So at the very bottom of the screen.
Yep.
I think if you do a Google search for Baycrest store, you should find it that way. But that's the direct link at the bottom of the screen there.
I think people can also navigate to the store from the Baycrest homepage, which is basically www.baycrest.org. Okay, so hopefully that that will help several people. And yes, thank you, Kim. My mistake. If you want to speak with us in like real voice, raise your hand. Another question. Someone has asked, what disciplines are delivering the training for your program, Brendan?
Great question. So our program is based out of the Neuropsychology and Cognitive Health program at Baycrest. The people that administer it there are mostly neuropsychologists or neuropsychology trainees. So that's clinical psychology students under our supervision. That doesn't mean that psychologists are the only ones able to administer. We see a variety of rehabilitation workers able to administer the program as long as they read the manual and understand what the procedure involves. So whether that's OT or other, I don't think we have any specific that way.
Okay. Is this training specifically for TBI clients, or can it be used for other clients?
Okay. So most of our clients have acquired brain injury, and that tends to be the clientele that have moderate to severe memory difficulties. If a client has too mild a difficulty with memory, this might not be appropriate. They might already know how to use their phone or be able to teach themselves. And I think that's up to the clinician to make that kind of judgment. Sometimes when we have clients referred to us with more severe TBI injuries, they have a lot of other complications rather than just memory, and we have to sort of take that on a case-by-case basis. So if you're asking about other than those two, for example, neurodegenerative, we found that it hasn't been as successful in that population, as we're sort of working against a continually progressive condition. So what we like to say is stable brain injury with memory is the most significant concern, but I'm sure there's some wiggle room, depending on the individual client.
And so this might be a somewhat related question that's come in. Do you see any differences in training outcomes based on things like diagnosis or even age? And then they've proposed ABI versus TBI versus other. You've spoken a bit about like neurodegenerative versus ABI.
We haven't found that. We haven't actually done any specific research to compare those, but I think that there are other more specific factors that might be more relevant than like overall type. So, for example, whether there is the presence of significant executive dysfunction in addition to memory, that could be a factor that prolongs training or means that training is more difficult to do. But in terms of the different diagnoses, I don't know if I can broadly say like this diagnosis is more problematic than another one.
Okay, so there's quite a few questions coming in along this lines. I'm trying to figure out how to maximize the time that we have with you.
Sure.
Let me jump to one. It sounds like the users need many sessions to master the training and be independent. Wondering if it could be adapted to more shorter stay inpatient settings, for example.
This is very client dependent. So as I mentioned, we see moderate to severe memory difficulties. If it's more on the mild to moderate end, yes, it's possible that someone could benefit, but I think at a more moderate to severe area, unlikely that a shorter adaptation would be successful. Often these clients need many trials of repetition to learn these skills. Yeah, that's the unfortunate consequence of the memory impairment.
Okay, thank you, Brandon. There's a couple more questions that are kind of talking about sort of, I guess, recruitment into the program. Wondering about how you draw clients with respect to how some memory functions are more important, and is that kind of a trigger for some people to want to take this training, or is there a minimum level that you want a client to be functioning at for them to benefit from the program, regardless of where the memory impairment is falling? I don't know if that's like way too broad a question. I'm trying to combine a couple of questions that have come in.
Sure, no problem. In terms of minimal level of functioning, I'd say, if what we really want is for someone to be stable following their brain injury. So we likely wouldn't see them, within the first weeks of their injury. It's more common to see them several months to, a year or more later. So stability is critical, as there's various changes that occur at that early stage. We also, depending on various factors, we would say that fewer complications make the training smoother. So if there's comorbid depression or other kind of psychological difficulties, we would recommend those be dealt with first before doing that type of training. But in terms of minimal level of functioning, other than those sort of basic requirements, I don't think so.
Can you recommend where the people in the audience could get more info regarding errorless training?
Well, there's the book, of course.
Yes.
There's also, I think for errorless learning, I would only know about journal articles. So there's, as I put up on my slides earlier, there's the seminal paper by Badley and Wilson from 1994, but there's been a variety of papers written on errorless learning. I don't know who has access to these, so that might be a barrier, but I think I hesitate to say Googling, but I mean, that's not going to get you the training to administer it. So
okay, maybe people have access to like a hospital-based library that would be able to help them with some searching. Yeah.
We definitely go over it in detail in the manual and explain like how it's applied.
Right. Okay. And then someone has asked if you could maybe spend a couple of minutes talking. You talked about, in looking at outcomes, you talked about improved confidence, both from the perspective of the client and from the caregivers. Can you talk a little bit more about that? That's piqued the interest of a couple of people.
Oh, so this was just based on questionnaire data from a study. So it's if someone was to asked, how confident you are in a variety of different memory tasks or in your ability to, utilize memory strategies. If we look at pre compared to post our program, we found that people rated their confidence as higher. So they had better confidence in their memory ability when using the various strategies that they were taught compared to before our program.
And caregivers noted the same confidence, or I guess I'm wondering about the comparison. What were the caregivers reflecting on? A noted improvement in the confidence that they saw in the person participating?
Yes, they were commenting on the participants' confidence, not their own confidence. Yeah.
Okay. All right. I just wondered, for a family member who's worried about someone living alone who's starting to decline, are they more confident now that mom's okay living alone? But that's not what you were asking.
Yeah, it's not their own confidence. It's their observations of the confidence in their family member.
Excellent.
Yeah.
Thank you, Brendan. I'm very conscious of the time. I have not seen anyone raise their hand. Is there anyone else who has any last question for Brendan? I see something has come in. There we go. Any other questions for Brendan before we wrap up? Really good interest, Brendan. Thank you. It's really such an important topic, and I think it has great ramifications for all of us and the clients that we're working with. So I'm going to say thank you. Seeing no further questions, thank you very much for sharing this.
Can I add one final comment?
Of course.
If anyone thinks of a question later or is interested, I do have a poster in the poster session on the same topic, and my contact information is there. I think it's poster 35. Now I'm forgetting. Could be 32, something around there.
Something with a 3 in it. You don't remember?
Yeah. It's in the program, but my contact information is there on the poster as well. So.
Excellent. That's great. Thank you, Brendan. Okay, everyone, thank you very much for joining us for this presentation. We're right on time to wrap up. We have a short break before the rapid podium presentations begin back in the main building. So everyone is released, and go check out the posters and get more information about